Let me introduce the last speaker, Dr. Bob Harris. He received his Bachelor of Arts in Biology and his Doctor of Dental Medicine from the University of Louisville. He was a captain in the U.S. Army Dental Corps until he opened his own practice where he is currently today. He also co-founded the American College of Integrative Medicine and Dentistry, where he currently serves on the board of directors and chairman on the Scientific Review Committee of the Institutional Review Board. In his spare time, which is very little, he has lectured nationally and internationally on multiple dental medicine topics. He is, of course, nationally and internationally recognized speaker on the use of oxygen ozone in dental medicine, and he's my adopted father. Bob Harris.
Thank you, son. Couldn't have picked a better one than that. So I have 3 daughters, no sons. So guess who my son is? He's walking right down there. And I'm very proud of that. So we're going to go through this, and we got a couple hours to go. And what I want to touch on today is what we start off with the Periodontal and Associated Soft Tissue Committee, trying to decide how we're going to handle all the perio issues that jump up in a biological manner. Okay? So the goals are to talk today about the official position of the IAOMT on perio and how are we going to integrate this in a biologic manner in our offices, our practices, and with our patients. So here's some late breaking news, and that's put these slides in a couple days ago. If any of you are following this along on whatever they give you, there's slides in here that aren't on the USB format that you can get tomorrow from Farah. She'll have them if you want to download any of this. But here's from the AGD Impact, February 2018. The correlations between oral diseases and systemic conditions are now broadly accepted by both dental and medical practitioners. 7 of the 10 leading causes of death reported by the CDC can be connected to inflammation and or microbes, guess where? In the oral cavity. And the diseases are heart disease, cancer, chronic respiratory diseases, Alzheimer's, diabetes, influenza, pneumonia, it goes on and on. The primary oral conditions contributing to these conditions are periodontal disease and the pathogens associated with perio, endodontic abscesses, and carcinogenic bacteria. So, in the Postgraduate Medical Journal, November 2016, Bale, Deneen, and Vigorist said this landmark study said, level A evidence now. I come from a family that my dad's a lawyer, my brother's a lawyer, my daughter's a lawyer, she's married to a lawyer. When you read stuff like this and you come from my background, it goes, alarms go off and flags ring like on old, Danger Will Robinson on Lost in Space. This landmark study said level A evidence supports a cause and effect relationship between periodontal pathogens and arterial disease. Okay? The periodontal pathogens actually inflame the lining wall of the artery, and it makes LDL cholesterol able to extravasate out there, and this is the beginning of arterial disease. So high-risk bacteria present in periodontal disease are now considered a contributory cause of arteriosclerotic vascular disease, including heart attacks, strokes, and more. But it gets better. Collaboration between dentists who practice oral systemic health, that would be us, and medical providers who understand that high-risk periodontal pathogens are causal of arterial disease. Well, what you look in here is essential for heart attack and stroke prevention. Arterial inflammation due to high-risk periodontal pathogens is a potentially, and this is where it gets really good, lethal medical problem. But now the next sentence says it all. And the solution rests in the hands of us. Okay, so somebody has a heart attack, and he says, I think they didn't clean my teeth right the last time. It's probably that dentist's fault. I'm like, what? So in the olden days when we were worried about perio and probing and maybe losing a tooth or something like that, we're moving way beyond that now as far as how the medical community, not all of them, but the guys that I practice with are definitely up on this right now around Louisville, Kentucky, where I practice. I always look at some of the lectures and say, why don't they define stuff other than just talking about it? So I like to put stuff on the slides so that you can review it later and not have to listen to me ramble on and on. Oh, wait, there's that definition of periodontitis, he said. And then try to write it down. So here's periodontitis. This is a conglomerate of about 10 definitions that I looked up over the last 3 or 4 weeks. So it's a biofilm-induced chronic inflammatory disease which affects the integrity of the tissues that surround and support the teeth, like we know that. Periodontal ligament, gingiva, alveolar bone, collectively known as the periodontium. It may exert an adverse impact on systemic health. However, and this is what's really important now because this gets to the heart of the situation, it's the effect of the immune response and not the inflammatory processes. It's not the mere presence of biofilm plaque, which we're always so interested in getting off the teeth. There's another component to it. So, dysbiosis. Now, when you hear dysbiosis, you normally think of, Crohn's disease or something like this. But dysbiosis affects the whole gastrointestinal tract. Where does it start? Your mouth. Where's it end? Obviously, anus. 1 cell thick all the way through. So it doesn't take much to get it out of balance. So dysbiosis is an imbalance of the relative abundance of microbial species within an ecosystem. So you have an ecosystem in your mouth, you have an ecosystem in your gut, you have an ecosystem in your brain. If you haven't read a book called The Third Brain, it should be on your reading list. It's associated with the disease. Dysbiosis can either be the cause of the cause or the consequence of the disease. Another really important thing to grasp is homeostasis. And homeostasis is a condition of equilibrium or stability in a system, which is maintained by adjusting physiological processes to counteract external changes. So it's a balanced relationship between host tissue and the resident microbiota that prevents destructive inflammation and disease. So we've got to maintain a balance between what we've got going on in our mouth and what we've got going on systemically in the immune system in order for us to fix perio. So most dentists, like Dr. Kennedy was saying, you get out of school and they're in this box. And as long as I stay in this box, I'm not going to get any trouble, okay? And it's important to stay out of trouble. So you don't want to, be too crazy and go out beyond, what you want to do to maintain standard of care. But let's think out of the box. And let's think, how are we going to integrate all this stuff together? And then you can look at the forest, which is the immune system, and the trees, which would be microbes and biofilm. And we want to appreciate both of them. Let's just look briefly at the historical theories of disease. What causes perio? Well, there's been changing paradigms over the last 120 years. First in 1890, they said, it's easy. Bacteria cause cavities and pyorrhea. Pyorrhea, it means, if y'all don't know that old term, flow of pus. So Dr. Willoughby Miller worked with Robert Koch in Berlin. His postulates, the chemoparasitic theory of caries. He believed both caries and perio disease was caused by bacteria. Well, we moved on from that to the 1920s. Bacterial theory was abandoned because if you took the bacteria out of the mouth of someone that had periodontal disease and someone that didn't, the bacteria was exactly the same. Now, on that date, we only thought there was 5 or 6 bacteria at all in the mouth. Yeah, lactobacillus, strep. But every case of pyorrhea alveolaritis is initiated by irritation such as calculus deposits, bacterial plaques, faulty crowns. So the cause of pyorrhea is in the nature of the local irritant to the gingiva. So we're moving on from that. So we go to 1960. Microbiological tests prove plaque bacteria cause inflammation, not tartar. Plaque causes gum disease. With no seeming differences between bacteria and health and disease, inflammation was thought to be caused by an overgrowth of normal plaque bacteria. This is the non-specific plaque theory. And removal of all subgingival plaque became the standard treatment for perio treatment. So plaque causes gum disease. Then in 1979, we have the specific plaque hypothesis now. And Dr. Walter Loesch discovered that only specific bacteria are pathogenic. Okay? And then he said, while mechanical debridement remained the standard of care, the use of systemic antibiotics became more widespread. This is where I kind of came into this back in the 70s. I graduated from dental school in 71. And so this is when all of the drug reps came pouring into your office with, oh, look, Perio's caused by bacteria. You need to put all your patients on amoxicillin. And the ones you don't put on amoxicillin, we can put on other ones. If they're allergic to that, we can put them on, and then they came in and said, well, wait, it's even better. We got perio chips. We can put antibiotics right around the pocket of every tooth in the deep pockets. I'm going like, that didn't really appeal to me back then either, because the year before is the year I quit using mercury. So I was still being so beat up by all my friends around Louisville for saying that, mercury is bad. So 86, there's the first journal of oral microbiology and immunology. Now it's molecular oral microbiology. The study showed that it's the immune response that causes most of the damage to the periodontium, not the microbes. Look at that. I mean, that's 30 some odd years ago now. And it's all just catching up now in all the new literature that we have. So it's immunological disease. Okay, so, well, we know the periodontal disease prevalence, it's historical theories, and then the prevalence, who's going to get it in the population, and how do we get this anyway? I mean, we get it from the parent to the child. If the parent is BANA positive, everybody knows what BANA is, right? I'm going to tell you in just a second. So probability the child infected is 35 to 54 times better if the parent has microbes in their mouth that are benzol, DL, arginine, naphthalimide positive. Okay? So that's why they say BANA. So oral cavity at birth is sterile. Periodontal disease is communicable. Okay? And I mean, most of us, if it's communicable by that, should be dead by now. At least you've grown up, when I did. So anyway, major transmissions vector is saliva. Yeah, it is. And mainly anaerobes. Treponema dentacalis, Porphyromonas gingivalis. I mean, you got all these guys in there. Okay. So bacterial exchange during intimate kissing. Dr. Malika did this research, and he didn't let his wife find out. Okay. But 80 million microbes are transferred during a 10-second French kiss. So what he did retro math on it, because he said he'd never had one that only lasted 10 seconds. Okay, and so, if you know Phil, he doesn't tell you, he didn't lie about that. So some of the collective bacteria are transient. Okay, others find a niche on the tongue surface, and there was a mysterious periodontal disease in Sweden, and they had these two kids that had just massive perio, little kids, okay, like 8, 10 years old, and they couldn't figure the source of the infection. All other family members tested negative. Monthly plaque samples were taken for a year. Only the family dogs between these two families had an identical strain of, that's Agrobacter acinomaticans, and the dogs came from the same litter. Okay, so we used to have a guy that taught perio years ago that said you get perio from wives, dogs, and lovers, or something like that. So anyway, but that they came from the same litter. So perio prevalence in adult Americans, we classify this as 2 or more sites with greater than 2 millimeter attachment loss. We have 65 million people that are affected by perio in this country. Or you can have greater or equal to 5 millimeters pocketing with periodontal disease. And so we're looking at this saying only 0.6 of this 47% of these million people with gum problems ever bother seeing us. How could that be? Why so few? Well, they did a study. We're always doing studies, like Dr. Kennedy said. They're always doing studies. So let's see. Let's go ask all these people that are really educated in colleges what they think about oral health. And they all believe they had good oral health and they didn't really need to see a dentist. But this belief isn't corroborated by data. So we need to educate the patients. We need to really value patient education. And I tried to do a little bit of it. But who does the most in my office? My team. My hygienists and my assistants. I hear them all the time pounding them. If you don't get this plaque off your teeth, this this could potentially kill you. And they go, oh, kill me. What are you talking about? And then they go into their little spiel about, we had a patient that had a joint failure, a prosthetic joint fail from P. gingivalis. Same from the perio pocket, same identical strain. And then there's one in the literature from in Ohio, Case Western Reserve has that. So anyway, we need to educate the patient, and then if you don't have education in your office, you need to educate your team about microbial, biofilm, and the immune response. If you get nothing else out of this today, those are the two things you need to know to fix perio. Okay? What are we going to do to the biofilm, and how are we going to help the immune response? Well, one, we're all infected. I mean, we're 90% bacterial DNA and 10% mammalian DNA. And if we're all infected, we're all going to be able to develop biofilms. And we all have an immune system. If we didn't, you all wouldn't be sitting here right now. If your immune system was trashed, you're dead. So you have your primary immune system, which is your thymus and your bone marrow, and you have your secondary immune system, which is tonsils, lymphatic vessels, lymph nodes, spleen, and appendix. Okay? Now, we look at some of these lymphatic vessels in the neck, in the tonsils. These are in our ballpark. We need to look at those, and if they're inflamed, we need to fix them. I got some slides coming up later about that. So, what we need is a balanced immune system. We need homeostasis. So, here's what happens if you get out of balance. You have an internal threat. It's an autoimmune problem. This is dysbiosis, inflammatory bowel disease. Your immune system gets out of whack. The cytokines are going crazy. Tumor necrosis factors going like, hey, we're going to go over here and really rough these tissues up. And if it overreacts, you get this. If it underreacts, you get cancer, hepatitis, HIV, shingles, TB. But if you get allergic reactions, hay fever, sinusitis, the biofilm then forms the infectious part where viruses, bacteria, fungi, and parasites, all the microbes are here, and this is going back and forth. You've got to balance this. You've got to break up the biofilm, and you've got to feed your body the right substances to keep it healthy. And what weakens the immune system? Everything we're exposed to. You get on the plane yesterday, all this air coming through there when we're flying here. Viruses, fungi coming out of there, bacteria, they're just all floating around in the plane. Pollution, you got EMF on the planes now. So all these things are bombarding our immune system, and we got to be able to handle it. So how do we treat this polymicrobial immune system dysregulation? Well, item one, we have to disrupt the biofilm at the office, okay? We can do that. But then item two, you've got to do it at home. You got to get them brushing. You got to get them using a water pick or floss. You've got to have good home care. And two, we need to drain and balance the immune system. Drain it? Well, it's lymphatic vessels. So you need something like this. There's a company, Marco Pharma. They've got lymphatic drainage remedies. And these tonsils here are really, really bad. And so what I do in my practice when they come in like that, and you look at the surface of the tongue, this son of a gun's really sick, okay? They get tongue problems. You can inject those with ozone. But before I do that, I never just jump right to that. I say, you know what we have to do? We got to get you on some nutrients. We got you on get you on D3, lipophilic vitamin C. They've got some here, and homeopathics, probiotics. And then after I do all of that, then I'll go in to if we need to inject ozone into here, and that will knock those out. I just did that on my 20-year-old daughter this past year. She had a retropharyngeal abscess, and so bad they took her to the hospital from school, and so her tonsils looked about like that, and so they're going to go in and drain the abscess, and they're going to do surgery and take the tonsils out and all this kind of stuff. So I'm like, open up, Amelia. This is in the hospital where, I'm not supposed to do that. But popped her tonsils with ozone. Guess what? All of a sudden the tonsils start going down, and the retropharyngeal abscess clears up. And the physician, the ENT, said, this is absolutely amazing. I've never seen anybody recover this fast. I said, yeah, well, she's a pretty strong little girl and all this kind of. I'm not saying, well, I was in your hospital and, I'm not on the staff and everything, and I've got these syringes loaded up in my pocket, and ozone lasts for an hour in a syringe, and I figured it's going to take me an hour when nobody was looking, and I told my wife, get in between the camera and the bed, and don't bump, and I fixed her. Okay, so we can do that. We've got the technology now to avoid antibiotics by and large. Okay, so etiology. There are two criteria for perio. Okay, one's pathogenic microflora, like we talked about, and another susceptible host. 75% disease prevalence in a susceptible host. Are all these caused by genetic mutations? That's what they would want you to believe, but it's not really likely that there's that much genetic mutation going on that's causing this, okay? Much more likely is the person's immune system is breaking down. It's being torn up by, fast food, too much sugar, not the right nutrients, all this kind of stuff. No sunlight. I mean, there's so much to, keep you healthy. Okay, so what we want is the obliging host there, and then the immune response plays the game here. This is 1 and this is 2. These two things have to occur simultaneously, or you don't have perio. Okay? So we should be able to take care of some of this on our own if we just break up all the pathogenic microflora there. So, while pathogenic bacteria initiate the inflammation, it's actually the immune response that does the damage. Now, if you see repetition occurring in any of the lectures, that Phil and I are big repeaters of stuff in lectures, it's because repetition is a good teacher, but it's also because if you want to use any of this stuff in study clubs that you all are talking to, do it. Okay? So out of 200 slides, you can't do it in a half-hour, 45-minute study club. So you can pick out a half an hour to an hour presentation out of here. Okay? So, because once the immune response kicks in, guess what you get? You get enzymes that break down collagen. You get enzymes that upregulate osteoclasts. You get all this stuff happening around the teeth, in the blood vessels around the teeth, in the bone. It shuts down the blood flow. You run out of oxygen, and the bone dies. So then you get this terrible smell from the perio people because the tissue in there is dying, and it's producing these really nice things like putrescines and cadaverines, which is the odor that comes off a dead, decaying body. And so we want to get rid of those. So how do we know whether it's healthy or not? Well, health gives you gram-positive bacteria, aerobic, there's few white blood cells, no spirochetes, and it's not motile. Well, the microbiological differences are in disease, mostly gram-negative, anaerobic, mainly white blood cells, many spirochetes, and highly motile. So when you look at this, non-pathogenic biofilms, the typical species are predominantly gram-positive aerobes, these guys. And a few white blood cells, not much inflammation. So when you look at the pathogenic ones, they are predominantly gram-negative, and they're anaerobes. Everything that's bad for us is anaerobic. Everything that's bad for us is acidic. When you have infection in the periodontal pocket, what's in that pocket? It's acid. What breaks down the hardest structure in the human body? Acid, produced by little bitty tiny, you can't even see them, bugs. Are you kidding me? How can they produce an acid that's strong to eat our teeth up? That still amazes me to this day after 47 years. Now, so you get this Kransky's red group. Okay, these three guys are constantly supported or show up in really bad cases of perio. But also these other things show up. Gram-negative facultative anaerobes and positive anaerobes. You got fungi in there, You got many white blood cells and a lot of inflammation. So oral biofilms are the thing. Plaque, we're still saying it, but it could be, kind of passe. And the biofilm could be anything, could be last night's pizza, but it's usually mucousy, there are microbes in there, you got some tissue debris. Usually it's some combination of everything in there. So let's say oral biofilm and not plaque is what we've decided. Phil and I talked about this at great length for a lot of times while we're just doing the advanced ozone course. How are we going to deal with all of this. And then we, decided that, the GI tract biofilm, it creates dysbiosis. But most people think of dysbiosis down here in the colon with leaky gut. But it actually can start up here in your mouth, the dysbiosis can. And it can actually, like a chemical reaction, go both ways. Which way is more susceptible? And so you've got your digestive system from the mouth to the anus. And so biofilms can form anywhere in there. Biofilms can form in your alveolar sacs in your lungs. Only way to get that out, you got to breathe stuff that would break up the biofilm, which is an ozonide gas. So but you got to be able to do that. Now here's the biofilm, how it forms. And this is scientific stuff, and it's kind of cute, and the slides are nice. But they form pili. They attach cell to cell. They twitch, and they get up against each other, and then they send each other these signals with cytokines, and then they put the little fibers out to consolidate and hold together. But the interesting thing is, let's kill them with antibiotics. Guess what? When they're in a biofilm, they're 500 to 1,500 times more resistant to antibiotics than when they're just floating around in the bloodstream. They're called planktonic versus the sessile forms. They love to get in there and shut out all the oxygen because what? They're anaerobes. You think they're going to say, hey, let's get oxygen in here because it'll kill us. No. We want to, and they're always shedding new cells to form new colonies. So, when the biofilm's forming and you keep it broken up all the time by brushing and proper oral hygiene, there's a few pathogens, but they really can't get around to producing toxins because they're too dilute. You have to have a critical mass. So how do bacteria know when they have enough neighbors to start producing toxins? It's called quorum sensing. They send out these little chemical signals to neighbors saying, hey, I'm over here, where are you? And then they switch these genes on and off, which shut down certain polymorphonuclear leukocytes, the PMNs, okay? And they change the cell machinery, and they actually hijack your immune system against the good competitors. So now you have a toxic mature biofilm, and the immune system, then it hijacks the immune system polymorphs, which are the PMNs, and they attack competitive microbes. So now these are really stronger than your normally occurring oral flora, and they start knocking them down and suppressing them. And then the things that protect us, the polymorphonuclear leukocytes, are poisoned. Then you get cell death occurs, and they release enzymes that surround the epithelial lining of the sulcus. When the sulcus breaks down, the epithelial lining breaks down. Now all of these pathogens have a way to become systemic pathogens. They can now invade us. So dental biofilm, we see this all the time. Thick grouping of microorganisms, bacterial plaque, 1,000 times more resistant. But now, Montana State University, their department of microbiology, they're big into biofilm formation. And this is tooth surface inoculated with plaque from someone's mouth, and it's now time-lapse photography in the 17th hour of the inoculation. And the biofilms kind of are talking to each other, and you see these things kind of, coming in and attaching, and then another one comes in, says, and they're putting out all these chemokines and cytokines, which is how they talk to each other. And they're saying, hey, we're going to have a party over here. There seems to be a pretty good food source. Oh, now here comes, look, the spirochetes start coming in. Now these are the bad boys, but it's all flowing around. They're all going around talking to each other saying, let's get hooked up here. If we get these two guys hooked up here, we can then protect everybody in here from any antibiotics. So this is a sessile form of a biofilm, and these are planktonic forms. If you remember your biology, planktonic, phytoplankton is floating plants, and zooplankton are floating animals. These are the planktonic floating forms, and these are the sessile forms. As the sessile form builds up and more reproduction occurs, then they start shedding new planktonic forms out to find another place to settle down in your system and form another biofilm. So here we go, 22 hours in, and it stops after 24 because guess what? That's about how long it takes this plaque. See all the channels in here, how the thing's flowing around in here? Because the biofilm and the plaque actually can slide around in your tissues and move. So there's why you need to brush your teeth once a day, huh? So when the biofilms move, you get crevicular fluid flow. It takes it onto another tooth. Then you look at them, and that's what, it looks like that. And, So biofilms, how fast do they grow? Well, let's look at them in a petri dish. How about E. coli? Under ideal conditions, watch this. Boom, that's, one E. coli. They double every 15 to 20 minutes. So they can move pretty fast. So biofilms, physical chemical disruption, destroys the biofilm ecosystem. That's what we need to do. We need to clean them up. We need to keep them brushing. We need to do, different things like we do with ozone treatment to them. The biofilm must reorganize from scratch through all the early phases to become pathogenic again. So if you break them up every 24 hours, that's all you need to do. But get some of your patients to do that sometimes is tough. The regrowth is sequential. It may take days depending on host defenses. Thus, consistent biofilm disruption is effective for disease control. I'm glad my guns don't have that trigger. That's a very sensitive little trigger there, a hair trigger. So bacterial tissue invasion, the significance of it, well, we're looking at perio disease and tissue invasion and a reservoir for reinfection. And so what's all of this doing in our body? Well, when you have perio and then it invades your tissue, where does it end up? As a systemic disease because it gets into our bloodstream. Then it can go anywhere. It can go to prosthetic joints. It can go to the lining of arteries. It can go everywhere. So when we look at this as systemic disease associations, perio has all of these things. I mean, we know this. We've seen these studies in the past. Peripheral artery disease, cerebral vascular disease, rheumatoid arthritis, osteoporosis, all these things. We have terrible things. And a lot of these studies have been done. And this was one done in India in 2014. And you can go back and read these, but there's more than enough evidence to quote an autoimmunity aspect of periodontal disease, which could be the main reason why initiation and progression of this disease is still unclear. You look at these and, University of Pennsylvania Dental School, they're still having trouble figuring out how perio begins. And so when you look at a review of what we talked about so far, it's biofilm, not plaque. All biofilms aren't pathogenic. It depends on which microbes are present. The periodontal disease is a microbial infection, but it's inflammation that does the damage. It's not the bacteria, it's not the virus, it's not the fungus. It's the inflammation that's caused from the immune response. The microbiology of health and disease are different, and you get biofilm plus host inflammation, and you get the immune response going there. And that's what's going on. So you have weird cases, though, that don't follow everything. Like saying always and never is not really good. So everything looks great. They have minimal pockets, no bleeding, and no mobility, but their bone is just going away from their teeth. And I've got several patients like this. So on those people, you've got to look at some genetics. What kind of drugs are they on? And the genetic part is like these people that have, you've got to get them tested for certain weird things in tumor necrosis factor and hypercoagulability. If they clot faster than the average person, they're going to have a lot of problems, and they're going to be a lot of problem for you because they continue to have periodontal issues with no inflammation, with no pocketing. The bone is just going away. And it's really sad. I've got a girl right now. She's 31 years old. She's got like 14 teeth left, and she's not going to have those much longer. And they put an implant in on her. Failed. So there's some of these things that we don't have answers for. So, but to jump on to, Dave's bandwagon about fluoride, what do you think? Look at all these drugs. I mean, all these things, guess what they all have in common? They all have a fluoride molecule on them. Celebrex has a fluoride molecule. Now, why would you think we'd put fluoride on there? Because fluoride improves the uptake. Like he was saying, there's certain things you can add to things that will increase their uptake as a drug. One of them is fluoride. So that's one thing you have to look at. Any people taking all those drugs, when people are taking Prozac and then they go out, buy an automatic weapon, go and shoot that stuff up. Some of those drugs they're supposed to make you calmer. Sometimes they'll make you crazy. Okay, so periodontitis is an infection that results from an imbalance. So we're going to talk about that again between the periodontopathic microorganisms and the local and systemic host defense. Homeostasis, you got to keep balance in here. And we'll talk about that, as we go. So there are basically 4 phases of periodontal disease. And in all the literature from probably around 2006 or 8 through 2015, a lot of this information comes from. I've looked at some of the newer literature, and it seems to be a repeat of the older literature where they keep doing the same studies over again, expecting to get a different result. Now, sometimes that's crazy, but they keep let's do replicate of that. So a bacterial biofilm and development of host response in the marginal periodontium. So that's step 1. Okay, biofilm formation is step 1. The innate immune response leading to gingivitis acute phase. Step 2. Step 3, the role of the adaptive immune system in attachment loss and pocket formation. The chronic phase. This is where you get into all the interleukins and the tumor necrosis factor issues. And then 4, downregulation inflammation and periodontal regeneration and repair following, guess what? Biofilm removal. So we are in this area where we have to take responsibility and take charge of the situation and not let us go along where we're saying, oh yeah, you need to brush your teeth a little bit more, come back in 6 months and maybe that 5mm pocket will be better. 5mm pocket doesn't go out without getting some treatment. We irrigate it with ozonated water, we put ozone gas down in there, we use oxygen and water versus any chemicals for all the treatment that we do as far as that goes. So, and then you have the phases of biocompatibility periodontal therapy. We're going to look at diagnosis, treatment, maintenance, and prevention. So, standard of care. You all know this, DNA analysis, irrigation, root planing, scaling, supplementation, pocket reduction procedures, frequent recall appointments, laser therapy. Lasers work really well on this, and oxygen ozone therapy. Now, lasers and ozone are going really well together right now. And if y'all haven't ever looked on a YouTube video, it's called PIPS treatment, P-I-P-S. It's photon-induced photoacoustic streaming. You ought to look at a couple of those things because it's really amazing what the new laser therapies are able to accomplish, both for periodontics and for endodontics. Well, this is a quick trigger. So diagnostic concepts, we're going to look at pocket probing. Sulcus depth by itself is not an indicator of disease. Sometimes it's just inflammatory, like you get a kid in with braces and you probe them, they have 5mm pockets. You take the braces off, the local irritant's gone, they rinse with salt water, they clean up, 2mm pockets. So that can happen in people without braces if they've got local irritation on their teeth. You probe somebody with subgingival calculus, you'll get pretty good pocket depth just because of the hypertrophy of the tissue. You clean that off, and those cells suck back to their normal. It's hypertrophy, they increase in cell size, not hyperplasia, they increase in cell number. They'll suck back to their normal cell self, unless they've scarred in, and then that's a problem. Okay? So tissue tone, maybe we need to look at that. So periodontal tissue should be firm and pink. You should still have some pathology in there. Swelling and redness are common clinical signs of periodontal disease. Yeah, it could be related to other systemic disorders in the patient. So somebody comes in, a patient I had for years, from the time she was like 11. She goes to nursing school. She moves to Cincinnati to go to nursing school up there. And she calls me on the phone. Dr. Harris, what? It's Patty. I said, yeah, Patty, how you doing? Good. I just went to the dentist up here. He says I have 14 cavities and I need gum surgery. Okay. That sounds pretty crazy because I saw you like about a year and a half ago before you moved up to Cincinnati to go to the nursing program. She came home for the weekend. We even went in on Saturday to see her. Her gums were like 20% overgrowth on the teeth. They were so swollen. And she had plaque everywhere. And she had probable cavities. And I was like, this girl never had a cavity in her life. And so, what are you doing? I mean, what's different? What's it? I mean, you're stressed and all this kind of stuff and everything. So we got down to it. She'd gone on birth control pills and changed her whole ecology. Like you'll see a slide coming up about a kaleidoscope. You do one thing to a person, you think it's just going to react here. No. You're affecting the whole body. So when you see those things and they come back and they're dramatically changed, you got to get a little bit deeper into their whole health history. What's this person telling you? And that's when it's really hard sometimes because you're thinking, they're going to talk to me. Oh, I've got a crown prep in the next room. I'm really running a little behind. I've got lunch with that. And you don't have enough time to listen to them. And, we'll always tell them, hey, I always want to take time to do it right the first time so I don't have to do it over again. Well, let's talk about this. And then we'll roll around to another room and tell, hey, I'm going to be a little bit longer over here. You'll be okay. And then the patient says, oh, I'm so sorry. I'm keeping you over lunch. And I always tell them, you don't have anything to worry about. I phased out eating and sleeping when I became a dentist. So it's just, you're first. As long as it says DR in front of my name and I'm practicing, you're first. Well, after God and my family, you're third. Okay. But I'm going to take care of them and I'm going to take enough time to do it right. It's similar to what Dr. Kennedy said. So it could be related to other systemic disorders. It could be prescriptions. Like I said, birth control pills. And that affected her hormones. So she had pregnancy gingivitis, but she wasn't pregnant. So get a good medical dental history if something like that happens. And bleeding upon probing or manipulation, it's not a sign of healthy tissue when it does that. You've got swelling and the epithelial cells stretch out, so it doesn't take much of an insult to get them to bleed. And it's due to inflammatory response due to infection or toxic exposure. I mean, I don't know where you all come from, but, Kentucky, we had some meth problems. Imagine that. And so, but man, these people come in that are doing some of these drugs. I mean, they're really, really messed up. So, and then when people come in with perio, you don't usually have to even go in the room. You can stand outside and go, perio. I was flying up to New Jersey with a friend of mine, Dr. Don Durbin. We were going up to the biological dental program that we have up there. And we sit down in this little bitty 50-seat jet, okay? And Dawn looks over at me and says, oh, no. And I said, yeah, it's perio. See, the guy in front of us, I mean, if you could smell it from an, airplane seat like this, so we're going like, oh, this is terrible. So we both pull out a bottle of peppermint oil and we're, doing peppermint so we can get away from the smell. But, this is a fermentation process. These people are fermenting. They're getting those putrescines and those cadaverines because they're letting they don't smell it anymore. How can they not smell that anymore? So I flipped around. I pulled one of her cards out. I didn't want to give him one of mine, and I kind of stuck my nose. She said, "Don't you do that?" I said, "I'm going to tell him you're a dentist." "No, don't you do that." So anyway, when you look at recession, abfraction, and mobility, occlusal issues will overwhelm the periodontium. And malocclusion does not necessarily create perio, but it'll push it along. And the problem you run into this over the years with treating, TMD and all the stuff like this is you'll find these people will come in and they'll be, I've got so much pain here on the left side, I can't stand it. Oh, they've got to do something, and my light's killing me. And he put articulating paper in. Oh, yeah, there's a problem. You grind that down. Oh, great, thank you so much. Great, they're gone. 3 days later, it's hurting up here now. Okay, grind that down. Oh, you got it, thank you. A week later, it's over here. Grind that down. Oh, great, thank you. 4 days later, it's back over here. It's here. So the problem is these people have compensated away from something that's bothering them. And so, and it's just, you've got to look at what they're doing, and if they're compensating, you've got to get that compensation factor out of there so you can diagnose them and treat them, because they're the hardest ones to figure out. So connective tissue disruption and bone loss, get apical migration of connective tissue and alveolar bone, and you lose cortical plate in an interproximal area. And, you got to take into consideration if the infection is active or if it's previously damaged. So we're going to look at microbial testing. Now, I don't do a lot of this anymore. I do like the microscope occasionally. Not for me, for the patient. So advantages of microscopes, chairside, you look at it, detects white blood cells, all 57 spirochetes, patient motivation. Because, and it's cheap, but the disadvantages cost you, what, a learning curve and, $2,000 to $5,000 to get a scope. And then you show it to your patient and say, oh, look, nothing moving around, or here's disease. And then you say risk assessment and the disease, because when you do that, it moves around like that under the scope. Took a minute for that to boot up there. So they look at a healthy one and they look at this, got spirochetes and everything running around in there. I don't use it for me. I use it basically for them. And in all honesty, and we haven't even used this a lot lately because of something that's coming up in a little bit. So if you're going to sample the plaque for that, where do you get it? Well, take a fine curator scaler, go really down into the apical third of the pocket, and then take and pull samples from your 3 deepest. Avoid calculus inclusions. And then the risk factors, you get white blood cells are inflammatory, you get the treponema, spirochetes, candida, trichomonads, amoeba, red blood cells. And typical low-risk biofilm, when you pull it out, it doesn't move around. And if there are few, if any, white blood cells in there are no spirochetes. You might find some candida in there occasionally, and you have hyphae and mother cells in there, and they'll tend to bud and come off and get chlamydospores on them if you grow them on cornmeal agar like we used to do in biology years ago. And they kind of look like red blood cells sometimes. So typically, though, they're smaller than a red blood cell. So the yeast have these branching filaments on them, kind of look like stuff growing on your bread at home. So Trichomonas oralis, these guys are running around like crazy when you pull them out on phase contrast. They're a protozoan. They're almost identical to Trichomonas vaginalis. They can't tell whether it's a separate or the same species. Probably the same. Not causal, but a useful marker. They're only found in mature pathogenic biofilms. That's the whole thing about that. When you see that organism, you know that biofilm's been on there for a while. And that's what they look like, under your scope. But they'll look a lot better than that if you put a scope on them. So amoeba, these are another protozoans. And so, they're dancing around under the scope. They're throwing out pseudopods. They're often mistaken for white blood cells. They have no cytoplasmic granules, multiple vacuoles, affinity for dead white blood cells. They're not causal, but another good marker. And they're typically found in mature pathogenic biofilms. So you can do microbiological tests. Culture and antibiotic-specific testing. If the phase microscope looks different, negative, and there appears to be disease progression, then you can do the BANA testing. And the Banazyme testing is a chairside microbiological test for periodontal risk. And it's rapid, takes 5 minutes, it's inexpensive, it costs about $6 a test, and it detects all 3 species of the highest risk red group, the Socrancy red group. And then there you got your Banazyme here. Advantages, chairside, 5 minutes result, detects the entire red group. It's as sensitive as DNA, surprisingly, and it's fully automatic, and it's cheap. It's about $6 a test. It only looks at 3 species, though, so it's semi-quantitative, but those 3 species are pretty common in all pathogenic biofilm. It's colorimetric. There's no written report. And it costs you about $400 for the equipment to get started. So there's more clinical studies on this than any other test, Banazyme versus DNA sensitivity, and it's about 95.5 to 100. So that's pretty good. And then you take a curette or scalar, go the apical third, deepest sites, smear lightly on the test strip. Don't like rub it around on there. You'll break the little film on there. And then your results will show you, I get that, blue areas cause a positive reaction. And here's what it looks like there. If it's colorless, salmon colored background, a minimum risk. If it's these pale blue, you got an elevated risk. And if it's positive, you get darker blue patches. And this gives you P. gingivalis, T. denticola, and T. forsythia are the buggies in there. And so the significance of Banna test in diagnosis certain forms of perio, okay? There's a positive correlation both clinically and statistically between Banna test results and the current stage of periodontal destruction. The Banna test results are not correlated with the degree of oral hygiene evaluated against plaque index, so the quality and not quantity of bacterial plaque influence the test results. So here's another one, salivary testing for perio, diagnosis and disease. The contents of the report and the visual presentation demonstrate that many patients have an active infection that can be stabilized if treated. That's what we're supposed to do. Patients also provide more information about other factors that may contribute to their periodontal condition. Further, the oral DNA report enhances dentist-physician communication and a team approach to care. I used to think that was important when I first got involved with Dr. Pratella, Dr. Nunez, Dr. Cruz, all the people that I work with at home. We got a big group with 2 dentists, 3 physicians, a naturopath, a chiropractor. We got a bunch of people on the team, but we're not really doing this much anymore, mainly because ozone kills everything, and I just don't waste the patient's money with all these tests anymore. But why am I talking about it then? Because somebody will say, oh, Harris did that perio lecture and he didn't talk anything about testing. He must not know anything about it. We know a lot about it, but we just don't really use it much anymore. Like you heard Griff say earlier, he doesn't do some things anymore. When you see it over and over and over ad nauseum, unless you just want to impress the patient with it, it really kind of slows us down a little bit. So the DNA tests, convenes multiple species, antibiotic guidelines. Yeah, that's what we want to do, right? Patient record form, disadvantages. It's costly, takes about 4 days to do it. And then you have these different diagnostics, the microident plus my periopath, 99, 129. And then my periopath switched with saline solution, spit out in the funnel, and report. You get the report back in 4 to 5 business days. And I've seen some of these reports from other dental offices. I've never done one of those myself. I got too far along before these were ever available. And so you dry the sites, insert the paper points. 5 paper points enable tracking 5 discrete sites. Transfer the shipment tube, and you get a report back. Here's what they recommend. Antibiotics. Amoxicillin, 500 milligrams, 3 times a day for 8 days. Flagyl, 500 milligrams, 2 times a day for 8 days. Put Arestin in around the pockets. Have them rinse with chlorhexidine. Well, I don't know. Do you want the people to have black teeth, with Paradex? I don't, I see people come in and have been rinsing with chlorhexidine for a long time, and there's a lot of stain on their teeth. So you look at medical and lifestyle status. Do they have systemic diseases? Do they have chronic disease, cancer, Lyme, physical disabilities? Are they multiple medical referrals to you? Nutritional issues, good physical exam? Do they have a good physical exam? What about all these tests? What about modifying their nutrition? Are they still smoking? Are they still drinking a lot? Now, good is it Kentucky, North Carolina, Virginia, Indiana still have the highest number of smokers of any state. So I see quite a bit of still people that smoke, but they're getting less and less and less. So you grow what you are. Just remember, primarily, our first nutrient we need to live is what? What do we die first without? Oxygen. minute or so, a couple of minutes. So that's one. But we can live without water for days and food for weeks, okay? So we need good breathing, and then we need good hydration, and then we need to look at our dietary requirements, and then habits. Do we have bad habits? Are we getting enough sleep? And, we just have to think about overall what we're going to do for our whole body, okay? So we want to be biocompatible, and treatment objectives is we want to disinfect the mouth and eliminate all the microbes in there. We want to remove as little healthy tissue as possible. We want to take the calculus deposits off so that we don't have a physical irritant, and we want to ensure the patient's lifestyle is conducive to good oral health. That means a lot of times you've got to talk to them, and you've got to have, Sarah, my hygienist, she's got to talk to them, and she's really good at that. And I use she and Jackie and Rhonda a lot to talk to the patients. And then I come in and kind of reinforce the stuff. So the principal goal of perio treatment is keep the biofilm in an immature state. Break it up every day, okay? And improve your immune system health. How do you do that? Well, getting enough sleep, eating well, hydration, like we just said over there. And periodontal therapy procedure, you want to do a comprehensive diagnosis. You want to look at, the pocket depth and probing in their tissue. And you can do a microscopic analysis, treatment cycle. These are all patient dependent. And when we treat a patient, when they come in and they sit down in the chair, have a little cup. It's got ozone water in it. Say, okay, patient comes in. I haven't had my rinse with my ozone. Okay, so we give them the ozone water, 30 seconds to a minute. Well, there's no viable bacteria in the mouth now. They're dead. So when you're doing your cleaning or your high-speed handpiece and you're creating this big aerosol around you that you're breathing, their stuff, there's nothing in there anymore that's going to hurt you. You've completely cleaned up that pathogenic environment that we lived in for so many years. And so Allison, one of my hygienists, she'd get sick every winter. And since we started doing that about 8 years ago, she's still missed a few days, but that's because she lies about being sick. Other than that, I'm really sick today. I can't come in. Okay. And then, at lunch you see her, at O'Charlie sitting there with her friends because it's Wednesday and you get free pie. I always know when she's off on Wednesday, I know where she's going to be because she and her buddies all go out. So anyway, we want to rinse with ozonated water. Now, what do? We put ozonated water in our water bottles on our unit. 3-way syringes and hand pieces are all coming out. And we also put it in the piezo scalers and the ultrasonics. So as you step on the pedal and the ultrasonics going around, ozonated water in there. Okay? So when we do this, we want to go in the sulcus and get all the pathogens out of there. So this is the first actual procedure that we ever used utilizing ozonated water to actually lavage out or rinse out the pockets. And there's a thing called a Viajet. I don't know whether that guy's here or not. Orajet. They sell those. Those are good. Those are like a water pick on steroids. It's got a little heater element right in there that heats the water before you put it on. And that's just what we use to clean out their mouth if they're coming in for ozone tray treatments a lot of times. So, 44. Okay. So, this is a long time ago now. The cover story of the American Journal, the Journal of American Dental Association, ADA Journal, periodontitis, an archetypical biofilm disease. And it states periodontitis is a classic example of a biofilm-mediated disease. And the article concluded that, and this is why you get these recommendations back from these places to put your patients on antibiotics. Periodontitis, like other biofilm infections, is refractory to antibiotic agents and host defenses because the causative microbes live in complex communities that persist despite challenges that range from targeted antibiotic agents to phagocytosis. The clinical implications concluded that the regular delivery of non-targeted antibiofilm agents, now that can also be iodine, okay, may be an effective strategy for treating biofilms, especially if these agents include oxidative agents that dissolve the biofilm matrix. And ozone is the third strongest oxidant out there after fluorine, which is toxic, and persulfate, which is toxic. So here's that journal that I referenced earlier, Oral Microbiology and Immunology. Now it's Oral Microbiological something. And this came out years ago, and it says that ozone, where is this here? Ozonated water strongly inhibited the accumulation of experimental dental plaque in vitro. After the dental plaque samples from human subjects were exposed to ozonated water, almost no viable bacteria cells were detected. These results suggest that ozonated water should be useful in reducing infections. Okay, and so this is when 2004, 14 years ago. So we've been looking at this now, doing this for a long time. So if you take the bacteria and expose them to ozonated water, 4 micrograms per milliliter, not a big heavy dose. Distilled water, nothing happens. Ozonated water, they start breaking down, and after 2 minutes, they're all falling apart, and the cell membranes all fall apart because ozone breaks the cell membrane down on bacteria. This is in the biofilm inside a water line. Distilled water, ozonated water, ozonated water. This is all done in Japan by Nagayoshi, and this is that same study that we looked at earlier. Distilled water, ozonated water, you start killing off. The green means the bacteria are dying, and they're after 120 seconds. So after you clean them up the first time and rinse them all out, then you go in and mechanically debride the areas. And then, again, you rinse them all out. And just replaning, we're just really light on that now. We don't do a lot of that. It's mostly with ultrasonics and piezos. And then if we have to replane, it's very judiciously. So when you take an integrative approach, you have to have the patient involved. You got to make them, and I tell them, I say, look, you're here for 1 day every 6 months. I can't come home with you at night and brush your teeth, and Sarah's not going to come home with you either, although you might like for her to. She's not going to go home with you and brush your teeth. We have to get you involved. This is a team. You are on that team, okay? And you are in our practice, which means you're a de facto family member. So we're going to talk to you like, I'm going to talk to you like you're my daughter or my sister or my brother. And I mean, sometimes the truth hurts, but you didn't do a very good job between last time and now. And if you want to have issues, keep doing that. But if you want to come in here, 30 years from now, and I'm not here, but another dentist is, and they're going to say, wow, look at this. You've been doing a great job for the last 30 years. That's what I'm worried about. I'm not worried about tomorrow or the next day. We can fix that. You're causing long-term breakdown, and you're also hurting your body and your overall health because this stuff is getting into your system. And then you got to play on some of that emotional stuff like that. Okay? So brushing, flossing, proxy brushing, non-toxic rinsing, we give some of the people ozonated water to take home and rinse. Let's have ozonated olive oil and all that. So we got all these different methods. Tooth and gum tonic is fine. Perio, cleanse, and all these are good. They're all nice, and they don't do anything harmful. And the toothpaste is good, and there's a lot of these really nice toothpastes and stuff now that don't have fluoride in them. And home care irrigation is not rinsing. Like irrigation is like getting it in there to the pocket and rinsing it out, which usually involves like water pick. So home care supplementation, you can use antibacterial oil pulling with coconut oil. You can use sesame seed oil too. Some new coconut oils have peppermint in them, which is pretty cool, and some of them have cinnamon in it. I like the cinnamon. My wife thought it was going to burn everything out of her mouth, but she's real blonde and real fair, and she doesn't do well with real hot stuff anyway. Vitamins and minerals, trace minerals. You really need the trace minerals to upregulate all the things that are going on in your body and your enzyme cycles. Bony support, horsetail tea is an interesting supplement. It's salicylic acid. If you saw what Dr. Kennedy said about fluorosilicic acid, when you hook those two together, silicic acid is a precursor to calcium formation. It comes from the horsetail plant, which was here in the age of dinosaurs. It's got really high nutrients. If you have horses like we do in Kentucky, and I grow horsetail in like these 55-gallon barrels that bourbon used to be in, and you can't plant it around your ponds or it'll just take over. You've got to confine it. But you let the horses out and they'll drag you over there to the horsetail tea. A horsetail plant rather, because it's so calcium inducing. And of course, when you have an animal that relies on the holding up 1,200 pounds on 4 spindly legs, they want to have their legs as strong as possible. So horsetail tea is interesting, and the salicylic acid's uptaken really fast, which was interesting when he was talking about how they combined that with fluoride. And healing and stimulating: ginseng, peppermint, chamomile, poultices, tea tree oil, anti-inflammatories. All these things are really, really, really good. Anti-inflammatory diet, avocados, broccoli. We basically use at my house and all my staff coconut oil and olive oil. And beets are really good. Beets naturally produce more nitric oxide, like you know. And xylitol. All the kids that come in, we tell them xylitol. We give them xylitol chewing gum. We give them xylitol toothpaste. And that stuff really works. I mean, it takes a kid that's a sugarholic and it gives them something to taste. That being an alcohol sugar, it's non-nutritive and it doesn't get absorbed. And so you can give it to even the kids that are diabetics. So the classic home care, people want to brush their teeth. They can use salt and baking soda. This is a real good book if you don't have it. This guy's an Oriental medical doctor, and he talks about sodium bicarb and how you can use it both as a mouth rinse at night, as a toothpaste, and then you swallow it to improve the pH of your body. Because what we're not looking at, and what I do with Dr. Cruz and the physicians that I work with, is the patients all take pH paper. It goes 5.5 to 8. Not the 1 to 14, 5.5 to 8. And every morning when they come out, before they brush their teeth, they take a piece of pH paper, get it in saliva, they read the pH off of there. If it's in the yellow range, it's bad. If it gets bluer, it's more alkaline. And they write that down for 2 weeks. And they come back in and we look at it. It's 6.4, 6.5, the saliva 6.4, 6.5, the urine 6.2, 6.5. Boy, they're dumping a lot of acid. That's a lot of strain on your body. You need to do something to balance that out. Again, your body's out of balance. It's not in homeostasis. So you got to use something in there that will reverse all the stuff going on in the body and not damage it. And so it can either be sodium bicarbonate, there's other bicarbonates that you can use. And so, but anyway, that's a pretty decent little book if you ever want to read something, simple that gets right to the point. The bottom line, I tell the patients, we can do everything we can for you. If you're not on the team, I'm sorry, we'll do what we can, and I write it down on the chart. And Sarah writes it down on the chart because I don't want somebody coming back 5 years later and say, I just had a heart attack because y'all didn't clean my teeth. Oh no, look, we cleaned your teeth and we told you and we told you and we told you and we told you and we told you. So that's where your record keeping comes in. Okay? Just don't ever neglect writing stuff like that down. That'll save you worlds of problems. So on subsequent appointments, number based upon the patient's response, some people need to come in every 2 times a year. Some people need to come in 3 times a year, 4 times a year. I have people like to come in 4 times a year, and they don't even need to. They just like to come in, hang out, get their teeth cleaned. I said, well, your insurance is only paying 2 times a year. I don't care. I'm paying the other 2. I just want to, they like the feeling after they get their teeth cleaned like that. So, and then we go into initial therapy endpoint. We look for, idealized pocket depth medical, but really we want them looking healthier in there. And then we maintain them, custom treatment cycle on individual basis. And then we kind of get them in at, after we do the first treatment, 4, 6, 8 week intervals. That's when Dr. Malika's children there. So he's got bulldogs. So, and I don't think that was his pit bull actually. So surgery. Does anybody recommend periosurgery anymore? I mean, even my periodontist doesn't like to do periosurgery. He'll do a nap. He'll do the laser, but he's doing very, very, very little of this. But if we don't talk about it, somebody will say, well, you didn't talk about periosurgery. I don't really recommend it, but if the periodontist said, look, there's a local area that I think we can do this, and we can do a graft on here, and we can get bone growing back in here, and you can do the ozone trace, and we can grow the bone, then I'll say, yeah, okay, we'll do that. So here's Lanap, and this is most of my periodontists are using this now. And then I haven't actually seen this. They demonstrated this at a course a while back. Have anybody seen this little deal? What do you think about it? Was it worthwhile? It's a tiny camera, and it shows you down in the pocket. So healing periodontal disease using oxygen ozone therapy. Now, let's really get out of the box in a pure biologic sense. Keep in mind the epithelial cell. The concept of a cell is strictly only a morphological abstraction. It's really the cell from a biological viewpoint can't really say this cell does this unless you put it into its whole ecosystem. So linear thinking in medicine started out, and we were all very linear. Organisms are analogs to technical machine. You get a drug to sell the disease molecule with the disease caused. Linear thinking in medicine and dentistry, the drug kills the bug and immediate repair. But that doesn't work well with chronic diseases, like cancer and diabetes and stuff like that. So the human biology is like a web, and we're all intertwined. Every action gets a reaction, and everything's connected to everything else, like I referenced earlier. When you make one change in the person, everything changes. So you take 0.2 of a millimeter off of tooth number 30. Does that affect 19 or 14? How about it now they've got a slide in centric? You take one little thing, and then everything starts getting off. Okay, so it's always nice to know where you started, so you know where how everything is happening. Okay. So biological systems, they don't show linearity. They're highly interlinked, and they're energetically open and exchange information with the environment. But the most important energy to give to structure to give structure and organization to a biological system is inputting and processing of information. What the information is like cytokines. They go in and talk to you. Interleukin-1 goes in and says, hey, I'm going to break down the inner lining of this pocket, and I'm going to cause gum disease. And then the immune system says, wait a minute, if you're going to do that, then I'm going to secrete B lymphocytes up here to come down there, and I'm going to fight that bacteria locally, and then when it goes away, the interleukin won't affect that. That's what's going on all the time. So I'm a biochemistry kind of nut, and I love reading that stuff, which would put everybody in this room to sleep. But that's how this all works. And it's really fascinating. But the information that you're getting them, like nitric oxide. Okay, eat beet juice. What happens? Well, you get vasodilation. You inject ozone subcutaneously around the tooth. What do you get? Vasodilation, because it releases nitric oxide. All these things are signaling. We used to think nitric oxide was toxic. It's not. It's a very important energy and information carrier. So biologic information get a simultaneous presence of a non-random messenger and a response receiver. These are 3D molecules all floating around in our extracellular space, in the extracellular matrix, carrying information around. So what you have to determine is, will the cells get good or bad biologic information? Well, if they get good information, you have a normal cell, a healthy liver. If they get bad information or noise, it goes into cancer. So you've got to give the right information to your cells, which means giving them D3, K2, vitamin C, those things. So you consider the integrity of cellular and tissue ecologic relationships, the body ecology. It's everywhere. It's not just the mouth. We're responsible for this, but what goes in here goes all the way down through and out your gut. So you're responsible for that. And a lot of times you can look at that tongue and tell this person's not healthy. There's a guy that does tongue diagnosis. I didn't think too much of that 40 years ago, 35 years ago. And then somebody did a tongue diagnostic course as part of another course I took in TMD. I thought, how could this possibly be related? And at the end of the day, I was like this. Because it was really, really impressive what he did. So we have to remember we're a superorganism. We have 10% mammalian DNA, 90% microbial DNA, and the ecosystem of the body is dependent upon, guess what? First, your oral cavity and the bowel, then the blood, then the liver, and it goes on pancreas, pituitary, thyroid, adrenals, limbic. And so now I'm going to show you one thing here, and this is what I always say, and I didn't say it before this lecture. See how it's spelled pituitary? That's Dr. Malika. But I always say in Kentucky, we don't have any respect for anybody who only knows one way to spell or pronounce a word. So that bails me out on any slides that have spelling errors in them, okay? So, but I'm really OCD about stuff like that. I can't believe I missed that. So did you ever think how information gets to a cell, how nutrients enter a cell? How does oxygen get out of a cell? I know you were laying in bed last night going, how in the heck is that oxygen getting into my cells? I mean, and it's really hard going to sleep then. And then, oh my gosh, I just ate that dinner. How are those waste products that I just digested, how are they getting out? Where the heck are they anyway? Are they in my extracellular matrix? Well, okay, I'm good then, once you can come up with that. So here's the extracellular matrix. This is incredibly important. There's a book written about this, and it's really difficult to read. It's about Pishinger, but it tells exactly how the body works. So here's your epithelial cells. So the extracellular matrix is this area of tissue here that the nutrients have to come out of the capillaries and go to the cells to be utilized. And after the nutrients are burned up as calories there, and what do we use to burn nutrients with? Oxygen. Without oxygen, you don't burn your nutrients, right? Put the candles in jars, 2 jars. Light one, light the other. Put a lid on this jar, goes out, no oxygen. Eat a big meal, go to bed. You lay there all night, you're full, and you're not breathing. Your PO2 in your blood drops down 82, 88. You don't have enough oxygen to digest that food that you ate that night. What happens to it? The body doesn't know anything else to do. Make it, store it as fat. So do you have sleep apnea and then gain weight? Or do you gain weight and then have sleep apnea? It can go both ways. Most of these processes, like chemistry, are actions that could go either direction. So, and then the waste comes out of the cell into the extracellular matrix, where it's picked up in lymphatics and it's taken out of the body. So this is what it kind of looks like with an artist representation of a scanning electron microscope, what the ECM looks like. It's the terrain our body lives in. And the reality of the extracellular matrix or biologic terrain. Every function, every process in the living body involves this in one way or another. And so the reason that every cell in the body is nourished by the matrix. Okay? All waste products have to come out and go into the matrix. All immune responses and tissue repair happen because of the matrix. It permeates every cell and surrounds every cell in your body. And so the extracellular matrix is a unifying biologic field, and this is, again, another artist representation of an SEM. And, well, this is really tricky, this clicker. Human body is an open ecosystem where if you have something going on here in the plaque, it's going to get in the bloodstream. Now, here's all these bacteria floating around, and they go along and, oh, look, here's a really cool spot to hang out, and this is the intima of an artery. And now you start getting arteriosclerosis in there. Okay, so we're an open ecosystem. Everything is connected to everything else. And it works like this. Capillary cell, extracellular matrix, and the microbiome, which is called the third brain. The first brain is the actual brain inside your skull. Second brain is your enteric nervous system. Okay, the third brain is the microbiome of your enteric nervous system. And when you're driving down the road on the way to work, and all of a sudden you know you're coming up to a bakery, and you know they have apple fritters there, and you know that I don't want an apple fritter, but somebody else in me does. And darn, if your car doesn't turn into that bakery and you get an apple fritter, that's because you had a gut feeling. They make serotonin. They make all of these neurotransmitters, and they can control us sometimes. So you got to get control of them, okay? And the fourth brain is the microbiome inside your brain, the lymphatic system of the brain, only discovered in 2015 at the University of Virginia. So factors that influence cell biology, extracellular matrix, you got growth factors, and you have, vitamins, hormones, and then growth shape, state of differentiation, and biochemical responses of the cell. Homeostasis is another definition of that. I just like to salt different definitions through the presentation so you get other people's ideas too. The coordinated physiological process which maintains the steady state of the organism. So we said that earlier. And it's biologic elasticity. And the planet can endure winter storms, summer droughts, accidents, predators. You can endure all these things because the human body is made up to compensate and take it. Dentistry really drags us down with chemical solvents, infections, heavy metals, and environmentals. This all puts us into an anaerobic state. So if we're getting all this stuff as dentists, we need to learn to protect ourselves. Somebody says, I'm really happy that you take all these steps to keep me from getting exposed to mercury. And I say, I'm not doing it for you. I had to take these things out all day. I'm doing this for me. You're a beneficiary, but I've got to protect me and her and everybody in the office. And besides that, you're in my family now. And I would do this for a family member. And you don't get any treatment in here that I wouldn't do for my family. And so they're like, oh, no. So the unstable stuff of which we are composed of, learn the trick of maintaining stability, and it's called compensation. That's why if you put a new crown in and you don't get the bite adjusted, they come in, say put a crown on 18, they come in and they're sore over here on 2 and 31. And so, but you look at the crown on 18, it can't be that crown. There's no marks on it. I just marked it. It's fine. And they go like, I know, but it hurts over here. But how could that be? I know I had that in good occlusion. So I developed a little trick years ago. I have them chew on a piece of gauze, breaks the proprioceptive mechanism. Proprioception in the teeth, located in the buccal cusp and also the periodontal ligament. So you got dual proprioception in the tooth. And proprioception is when you can take your hand, make a circle, finger, close your eyes, and go into that. You can even do it, behind your back. So if you have them chew on gauze, it blows the proprioception up, put the articulating paper back in without letting them touch down. They bite. Now they hit 18. So you've got to get them decompensated to treat them. They're the most difficult people to treat medically or dentally as if they've already compensated. So, dysfunctional matrix, we can see if the matrix components are dysfunctional and toxic, then we get into this thing called dis-ease, okay? So a reflective ecologic environment, we want to take the mouth, the periodontium, from an anaerobic dysregulated environment that involves the dental biofilm and the immune system, okay? We want to shift that ecology from that acid-based ecology, and we want to come over here to where we have an aerobically regulated environment. And now we have homeostasis and health. And it all comes from us cleaning up the mouth and giving them something to help the whole overall body with. So when you look at the dysregulation in the periodontal pocket, we've got to think integratively. We can't just go like, okay, I'm going to fix this and it'll be better. We have to look at the whole patient and move them up to where we get them back in a regulated area where they're in homeostasis. And we've got to shift that ecology back to 7 to 7.2, okay, where the healthy cells live. So anaerobic dysregulation, you get vascular and lymphatic congestion. Now, this guy had a bad tooth here, and look at all of the necrotic bone around that one bad tooth. So obviously cadaver dissection. But this is your classic ischemic disease right there, where you have vascular and lymphatic congestion from infection. So osteonecrosis of the jaw. So this is one of Dr. Malika's patients, comes in, they got a hole in the roof of their mouth like that. They run bisphosphonates. Let's see, what did he have? prostate cancer. And they were worried about it metastasizing the bones. They put him on Beniva. And so he looked at him, he saw this pus-filled area up here. He starts injecting homeopathics and ozone around there. Piece of bone shows up. The piece of bone then falls out. And this is what it kept looking like as the bone kept falling out. And this is the floor of the maxillary sinus. This is the zygomatic arch. You don't think those bisphosphonates aren't some kind of bad boys to give people? But that's what it looks like now. Got it healed. It's regulated again. And now he's got a obturator up in there on a partial. And the guy's doing fine, But you've got to take a dysregulated tissue, boom, treat it, and get it back to homeostasis. And osteonecrosis of the jaw, periodontal disease, all of this happens through the matrix. You need to get oxygen in there. You need to give them all the naturopathic medical support they can get, along with allopathic medical support. Detox and drain, which we don't have time to talk about much today, but it's really critical. Hydration. Take your body weight, say weigh 150 pounds, 75 ounces of water a day. Your body weight divided by 2 into ounces. So 100-pound person, 50 ounces a day. So integrated biologic dental medicine uses all of these, and this all goes through the matrix. So we have oral, intestinal dysbiosis if we don't do all of these things to fix the patient. We just let them sit there and continue to get more and more and more run down. So it's our responsibility to fix that. So what do we want to do? We want to repair them. The first thing we've got to do that we can get to easily is get rid of that biofilm. Secondarily, we need to help them restore the microbiome with the right probiotics. And thirdly, after they're back, we need the body to be able to heal itself now by giving it the right things to heal, the right nutrients, everything so it can heal. So integrated biologic dental medicine, we should put all these pieces together because we got all this stuff floating around out here. What about the microbiome? Are we going to use biological medicines? How are we going to diagnose this? What are we going to do about infection? All of this has to be taken care of through the way that we treat the body through the matrix. So when you think about it, those were Dr. Malika's bulldogs. The patient has the innate capacity to heal given the correct integrative support. So that's what we really need to do. We need to support them. And the essential code for healing of injured tissue is woven into its structure and function. So healing is really a process that we can go through. So the principal goal of supporting and nurturing the extracellular matrix, and then we nurture the healthy epithelial cell, and then you get healthy tissue. So it goes like this. Homeostasis means that you have to have healthy cells. What do cells form? Tissues. What do tissues form? Organs. What do organs form? The organism. So you've got to start at the lowest common denominator, which is the cell, and fix it. That's why you have to do cellular detox, lymphatic drainage. You've got to do that. When you've got somebody that's got mercury toxicity, you've got to get them on a detox program that's not too overly burdensome for them and not to try to detox them too fast, or they'll go into Herxheimer reaction on you, get really sick. Most people that go on diets, most people that try to detox from mercury or heavy metal, they'll start on it and they quit. Why they quit? They get sick. They get sick because their drainage pathways aren't open. So they just don't get rid of the stuff. They mobilize it and then move somewhere else. You don't want to mobilize mercury from one part of your body and have it end up in your brain. You want to drain that out there. So it's a real complex thing. And that's why in the detox lecture that we have in the advanced course that we do, it shows the team that's involved in detoxing the patient. You try to do everything yourself. It's like, okay, I'm the best quarterback in the world. I just won the Heisman Trophy. And I'm going to go out here and I'm going to play this high school football team and I'm going to beat their socks off. And they kill you because there's 11 of them and one of you, right? So you've got to have a team around you for this to work. So I'm just at this, and it never worked for me until I spent a lot of time developing all these guys and girls. Healing and supporting periodontal associated soft tissue. Well, again, what we want to do, And again, this is just a different form of that other slide, from an acid environment to an alkaline environment, biofilm to no biofilm. What's the root cause regardless of disease? What's the patient experience? Talk to them, understand what the biologic processes are. This guy comes in to Phil, says, I've got this hunk of bone hanging out of my mouth. Well, where'd that come from? Well, I have prostate cancer. So then that's where you go back and you develop the patient history then, okay? And anaerobiosis. So in 31, Otto Warburg, an MD in Germany, got a Nobel Prize for finding cancer can't grow where there's oxygen. Can't grow there. And so he got a Nobel Prize. In 44, he got another Nobel Prize, even though it's during the war, and found that cancer grows like fermentation, like yeast grows. It's uncontrolled oxidative injury. And everybody in Germany, they're going like, yeah. And they started doing this. In 1980, a guy named Sweet in St. Louis, an MD, read Warburg's work. He said, this can't be. This is too easy. So he got some people and reproduced Warburg's work. They all got better. He goes, I need to tell American Cancer Society about it. Guess what? They didn't do anything about it. They said, no, cancer, chemotherapy, surgery, and radiation. What? When you can treat it very simplistically and not kill the patient? So oxygen metabolism is disrupted by these guys here, which we're exposed to a lot. Heavy metals, pesticides, solvents, all the trays that we make in the office, splints that resurface, and it takes you into an anaerobic type of environment, which we don't want. So periodontal infection is uncontrolled oxidative injury, and you go into vascular lymphatic congestion, and you get dysregulated cell function, and it all ends up with an ecology in that periodontal pocket that sets up to be oxygen-hating, acid-loving microbes, and those are the bad guys. So what do we need to do to get rid of this? We need to shift it. We need to go from the total anaerobic ecosystem and add in the nutrients and the therapies that we know how to do to shift you up to an aerobic situation. So the oral systemic link, and that was just, let's say, imagine, healing periodontal disease with only oxygen and water. Well, here we go. Fundamental facts about oxygen ozone. Well, it disinfects, it's non-toxic wound cleaning, it improves and accelerates wound healing. It activates red blood cell metabolism with improved oxygen release, and it activates enzymatic antioxidant free radical scavengers. That's important because they're what protect your healthy cells. So it activates immunocompetent cells, such as the release of cytokines, interferons, and interleukins, so it modulates the immune system. This is where we can really help locally reboot the immune system, and then it can reboot systemically if we get rid of the plaque and also get rid of some of the organisms in there that are causing the immune system to be hijacked. And you get increased antioxidant capacity through activation of cellular antioxidant systems, and these are catalase superoxide dismutase. And you get an anti-inflammatory effect. It releases nitric oxide. Say you inject some ozone in your mucobuccal fold above a periodontal pocket. The oxygen is released in there, and the ozone is released. And when it happens, it causes a release of nitric oxide, and then the nitric oxide gives you increased blood flow, and you get more electron transfer, and that's where electrons are negative and the acid in the pocket is positive. You need to reverse that acidity, and you can only do it with a negative charge. Negative charge is ozone. Oxygen, ozone, only gases that can accept and carry a negative electrical charge. Remember dysbiosis, it's a digestive tract problem, and we saw what that biofilm looked like in that little movie that we ran earlier. And dental biofilm. Don't call it plaque anymore. We call it biofilm. And these are a couple of microbes. Dumped them ozone water on them, and they break up like that. And this is a little zone where you look at hydrogen peroxide, zone of inhibition, mercurochrome. Yeah, let's put some mercury on it. When I was a kid, if I got a cut finger, my mother and grandmother, I was red up to my armpit with mercurochrome. It's a wonder we're still alive. So, and then there's iodine, and there's isopropyl rubbing alcohol, the ceremonial swipe. It really doesn't kill anything. So the biophysics of oxygen ozone in the body, it breaks down instantly, and it produces O2 and singlet oxygen, and this is what does all of the work, because that's a negative charge right there, and it just jumps onto all of the positive charged acidic pocket components that you want to downregulate. And ozone is produced in our bodies all the time by what's called the water oxidation pathway. Scripps Institute, La Jolla, California, 2012, they found that ozone is produced in our bodies by antibodies during bacterial killing and inflammation. So this is really a naturally occurring element that we're just using to boost up the body's ability to fight off infections when the immune system's been hijacked. Now, you don't do all that testing. I know. You don't do this. I know. Why? Here's why. They haven't found anything that hadn't killed yet. Okay? So and viruses, it even kills encysted protozoa. I did a study with the University of Louisville with bacterial endospores in sterilizers, and what you check your sterilizers with. Killed those. And those are the hardest ones to kill. That's why they use them in the sterilizer things. So primary issues in dentistry, trauma, infection. We're dealing with infection here. And how are we going to deliver it? When we clean the mouth up, we irrigate it with ozonated water. We inject periodontal pockets with ozone gas. Now, this is just putting it in there with a cannula and pumping the gas down in through a round-ended cannula. It's called a maxi probe or a vista probe. And then we inject the soft tissue with oxygen ozone gas. Everybody freaks out with that. Don't worry about it. We've been doing it since, 1999 now. Total saturation technique with oxygen ozone gas, which are ozone trays, and we use ozonated olive oil. So periodontal enhancement, outcome protocols, just do your normal diagnostics, standard of care. Always do standard of care. Even when you treat TMD patients, if they come in and you think, oh my gosh, their jaw's popping, I can inject that with a homeopathic and with ozone, and I'll have their jaw going like great. If 9 times out of 10 it'll work. The 10th time it doesn't, the person gets mad, and you didn't make them a splint, put them on a soft diet, all that kind of stuff. Just follow standard of care and just save yourself the aggravation of all of that. So this is what we do with our standard of care, frequent recall appointments, okay? And we always use oxygen ozone therapy. Periodontal treatment therapy procedures. Here you go, comprehensive diagnosis, microscopic analysis, treatment cycle again. And this is what you saw earlier where we actually rinse out the pockets with ozonated water. And I'm really sorry about this clicker. And after we mechanically debride them with a Cavitron or a piezo, then this is what we do when we set insufflation of the sulcus. This is a blunt-ended cannula. It's got a side vent on it. So you put that on a syringe and you go down into the pocket with ozone gas, and you slowly infuse the gas down in there, and it goes out into the tissues and rebuilds all of this. Okay? So it just goes in there, does that. It's just like putting a perio probe down in the pocket. Do you have to get all the way to the depth of the pocket? No. No, I mean, just to get down in there. Say it's a 6 millimeter pocket. If you're in there 4 or 5, you're good. Because the gas, if someone's out in the hallway wants to kill us and they've got a gun and we got the door locked, they can shoot all day long. They can't hurt us. They got a laser. They can shoot the laser and try to come through the door. No, it can't get us. We have the doors locked. Okay, now they've got poison liquid. They throw the poison liquid against the door. Runs down. We're still good. But what if they have a capsule of sarin gas? They drop the sarin gas against the base of the door there, and we're all dead in a few minutes. The gas can go where other stuff can't go. That's what makes ozone so effective. And ozone is negatively charged. Every bacteria, virus, fungus, parasite, all the inflammation all the infection is positively charged. It's acidic, and ozone is alkaline. So it sucks electrochemically right to where you need it to go. So it's almost like a heat-seeking missile. I mean, you just put it in there and it goes where it needs to go. Okay? So sulcus instillation, yeah, we use a dose of 20 microgram per milliliter. And I said dose because that's what we're doing. We're treating this kind of like a drug. Okay, and our exposure time is 10 seconds per pocket. We add a second for each millimeter beyond 5, That's what one of the ozone machines looks like, and this is an ozone handpiece that we come out here. It's got a little foot pedal that you can activate this. Your hygienist can go through and treat the pockets, and that's making some ozonated water right there. This is what the handpiece looks like, and this is one of the little maxi probes on there. Actually, we use Vista probes because maxi probes, you can get 100 Vista probes for what you spend for 60 maxi probes. So, and it's got a little foot pedal you can step on there. And we put it around the pockets, insufflate the pockets, go up there like that, down there like that. These are the trays. Here's the edge of the tray in the mouth. Ozone's going in here. Ozone coming out here. This is hooked to your suction, and this is a secondary suction to clean up any gas that would escape. And that's what it looks like in the patient's mouth. It's a saliva ejector hooked up, and here's ozone coming in here and going out to the cart there. And if you use a maxi probe and the gas, when you have this, you do this when you first start and start slow. If you put it down the base of the pocket and you inject up in there, all this stuff happens. Foaming, bubbling. These are all peroxides, lipo and hydroperoxides from the dead, dying, and blowing up bacteria that are in that sulcus. And then you come back 4 or 5 weeks later, boom, you put the gas up there, there's nothing. Now the inside of the pocket has healed. Now there's no biofilm. Now the immune system can't hijack all this infection there and create all the problems that you get systemically. So here you go. You have your CBCTs now, and you can see all this. And, some of these teeth you're not going to be able to save. But when you do vascular enhancement, this is what we're talking about. We're injecting gas into the soft tissue, and you get an increase of nitric oxide, L-arginine, nitric oxide synthase to L-citrulline to nitric oxide. And you get more blood flow in those tissues. You inject there. Yeah, we do that on all these perio patients. And this is what we want to do. We want to increase the periodontal blood supply because the periodontium has great capillary loops of oral epithelium to pick up oxygen. And when you do specific infusions, if you've got like an infection around the tooth that's pretty bad, you can actually just inject that tissue. It starts tightening up like that. And then when it gets tight like that, sometimes it doesn't get any better than that. And that's when you need your little laser to go zip, zip, and take off that hypertrophied tissue. And restoration of the microbiome. Whenever we do any of this, we always, I say always and never is bad, but this is an always. You always give them probiotics. And what we do is we take saline and we take the powder or crush up tablets, and we mix a solution, draw it up into a syringe, put it on the cannula, and go down and put the good bacteria back before the bad guys have a chance to take over again. And then we have the patient swish and swallow all of the probiotic, and then we put the patient on a routine probiotic protocol where they don't brush that gum line for 24 hours. We want all those bacteria to grow in there. Okay, assessment and recall. If the patient checks okay, we get them back in, look at them, lavage, mechanical debridement, and clean them up again. And normal home care, patients can brush with ozonated olive oil, they can floss with ozonated olive oil, they can do oil pulling. That's what ozonated olive oil looks like. And it's all a matter of ecology. It's all a matter of ecology. We are a superorganism. We're 10% mammalian DNA, 90% microbial DNA, and the microbiome is a reflection of you. So how you respond and everything. And like I was doing one of these lectures, a few years back, and I was talking about nutrition and how, we do this, this, and this, and this. This one guy's sitting up kind of close, and he says, "What do you think? By doing all that stuff, you're going to live forever?" And I said, "So far, so good." So if you do the right thing You've got to do it in order to be authentic to your patients. You know, if you're sitting there going like, I'll be right back as soon as I go out front and have a smoke, you know, and you say, no, you can't smoke anymore because this is hurting you. You can't do this, you can't do that. And you come in and you smell like cigarettes, you smell like alcohol. You know, you've got to practice what you preach in this. And once you start doing it, it's not difficult, and it's really hard to revert back to, you know, old bad habits you had over the years. So, Griffin, I'm done, son.
Thank you, Dr. Harris.
Finished.
Okay, Q&A. We can cover, let's try to keep it to the afternoon stuff, but you can ask stuff from this morning as well. Okay, who's got the first question?
Dr. Harris?
Yes.
So the last case that you just showed with the bone fill, the ozone, the perio, the last slide, how often were you doing the perio maxi probe? I didn't mean that. The maxi probe ozone lavage.
That guy was coming in
How
at about 10-day to 2-week intervals. He was a Dr. Malika's patient. He's a UPS driver, and so what he would do, he'd try to time it so he could have enough time, like 20 minutes near the end of his route, and he'd try to get ahead. And then they started saying, "Hey, why are you 20? You're been 20 minutes at this one office." You know, but he was doing it. He was doing it about once every 10 to 14 days. He did it for about 4 or 5 months because that was a pretty dramatic case. Now, we have people come in with 4 or 5 millimeter pockets. We do them 2 or 3 times, and they're good. Right, Griff? Yeah.
Sorry, can you talk about the probiotic with saline? I got confused on that one. How do you use it?
The what?
The probiotic with the saline, is that IV?
No.
That's what I thought.
We're just mixing that up so we know we've got a sterile solution.
Yes, sir.
And somebody said, well, mix it with ozonated water then. Oh, well, duh, what's going to happen? It kills it. It kills all the bacteria in there. It'll kill the good one as well as the bad. That's why we want to do the probiotics right after the ozone treatment so we can jump start the whole ecosystem in the mouth with anaerobic bacteria that are good for us. Yeah. Aerobic. Yeah.
Oh, so you're saying use the ozone treatment first and then the saline with the probiotics?
Yes.
Lavage.
Right. And that's why we use the sterile saline, because it's an isotonic solution, so the bacteria are not, you don't put them in there so it's not hyper or hypotonic. If you put too much salt or not enough salt in there, it will suck the fluid out of the bacteria and kill them. So it has to be isotonic.
And my second question, bleaching trays.
Is what?
Bleaching trays. Ozone trays.
Oh, ozone trays.
For how long, how often will you use it?
We do those 3 times initially. And what we do is we get the patient in, and if they're a new patient that's been referred specifically for ozone therapy, we'll give them the first appointment. They get the mouth looked at, impressions, and a gross scale. Okay? The second appointment, they come back, we fit the trays, and we give a fine scale. And then ozone trays, 10 minutes per arch. And then the third appointment, fine scale again, and again, ozone trays, 10 minutes per arch. The fourth appointment, there's no charge for that. We'll tell the patient, now, you've been doing so good. Now, they paid for it in the first appointment because they get charged for the ozone trays and gross scale, fine scale, fine scale. So the fourth appointment, they come back, and all we do is lavage, rinse out their mouth, floss, brush, ozone trays for 10 minutes. But that way they come back, and we can follow up on them. And then we keep the ozone trays because I've got plenty of room to store. The people in California, where I've been in a couple offices, they barely have time or room to turn around. So they tend not to have a lot of storage space. So they entrust those trays with the patient. They cost $100 a tray. They're custom made. Special silicone, sorry. They cost $120 now? Okay.
What's your gamma setting?
25 to 30.
Okay, back here.
Yeah.
Can I get some information on topical fluoride treatment and any alternatives?
Well, we haven't used fluoride in my office since like 79 or 80. Mercury was done in 78, and fluoride was done shortly thereafter because I started running into guys that were in the IAOMT, and they said, "Oh, that's great, you gave up mercury, but you got to give up fluoride." And so I said, "Well, fluoride's no, we need that." No, I said, "Well, what about fluorapatite in versus hydroxy?" I gave them all the left brain science, biochemistry, and then I started looking at what Dr. Kennedy had, which were the studies, and there's nothing there. There's nothing there you could hang your hat on scientifically. And if there's anything that I'm a nut about, it's left brain science. I want the science. I've got to know how something works before I use it. It took me 6 months to get up enough nerve to use ozone after I was initially exposed to it in 1998 at a naturopathic course. So, so the fluoride with what we do, if you keep the biofilm down, if those patients are working good at home and they're using some kind of toothpaste that doesn't damage the periodontium, if they're using baking soda mixed in with some toothpaste that doesn't have fluoride in it, any of these, there's so many options they have now. Spry toothpaste, Tom's toothpaste. There's so many options that they can do now just to keep that biofilm broken up. I think fluoride is just shouldn't even be in a discussion anymore in dentistry.
That you can use a deadly poison to kill a germ, or you can use a nutrient to kill a germ, and we're more of the nutrient kind of people because the deadly poisons generally don't stop killing germs. They kill whatever they come in contact with. So if you don't put deadly poisons in people's mouths, then you don't have to worry about the person reacting to the deadly poison. So, silver diamine fluoride, that's great. We will kill you if you swallow it. So, hey, just don't use poisons. It's just that simple. I don't use things that kill me. I use things that kill germs, like ozone and iodine and sunlight.
Sunlight, right.
Want to say something?
So in my practice, we don't use fluoride. We have a lot of kids. Parents come in because we don't use fluoride, but we use ozone. I mean, we'll ozone those grooves and everything, and if we see anything at all, even early decay, it'll go away with ozone. So that's what we do.
That's what he's talking about. You can blow ozone gas on a small incipient lesion a few times. I do it like once every 7 to 10 days, maybe 4 or 5 times.
How do you tell if it's arrested though?
You can feel it, you look at it.
But it's a process, you can't get in there.
Well, that's different. So you got to judge it by, so if this is a child, right? And there you know how their cavities grow fast. It has to be a small lesion. You say, look, I'm going to inject this in between. We'll take an image whenever down the road and see if it's grown at all. And if it hasn't grown, you don't cut it.
That's it. Yeah. Yeah, we just brought up Diagnodent, and there's another. Right, the Diagnodent? Yeah, no, and neither does SoPro or the other, those other types that we use. The Air Techniques one, which is the camera is the Polaris, and the Spectra. It's called the Spectra system, and it's a laser that reflects back certain light through a filter, and healthy enamel is green, early enamel caries is blue. You see blue on there, you can either use the Prep Start, the air abrasion, or if they don't have really deep grooves, if you just clean those out really well and you hold ozone gas on there for a minute, it's going to get down in those grooves. Okay, and then you put the Spectra back on there and get another picture of it, and boom, it's gone. The decay bacteria are dead. They're not putting sulfur components out anymore. Now, occlusals, interproximals is a different story. Then you would need the little tray things in there, and then you can get interproximal with those. But to do those on a kid, and those trays, I didn't know they're 120. Thanks for updating me on that. So that goes to show I don't pay the bills at the office, or I would know that. But the trays, once you get into adults, we'll get those, because those trays are blocked out, and they are good forever, because even if you do crowns or anything like that, so enough a block out around them for gas flow, you never have to make them again unless the patient loses them. That doesn't happen because we keep them.
Hello, doctor.
I have a question about the ozone trace. What concentration of ozone do you use?
25 to 30 microgram per milliliter, or gamma is the other term.
Oh,
Yeah.
the same than in pockets.
Uh-huh.
Okay, thank you.
Yeah.
Yeah, he's been waiting on that.
Now, when we're doing decay and we've prepped a tooth out and you go down inside the tooth, you use 45 to 50 then, because you really want to punch that down in the dental tubules and kill any bacteria that are down in there. So that's why there's different protocols for different things, and we've worked on those over the last 20 years, developing those protocols.
What are your thoughts on mainstream antibiotic prophylaxis?
The patients that come in, if their physician says this patient has to have antibiotic prophylaxis, I say, fine, take it. But what we do is we just load them up with probiotics then. And so, Dave, you had...
I have an opinion.
Good. Go ahead.
The scientific literature shows that scaling, root planing, wisdom teeth extraction cause a septicemia in 100% of patients.
Mm-hmm.
This is exactly where Semmelweis was in the 1800s when he said doctors need to wash their hands before they deliver babies. Why do you get a septicemia? Because you haven't disinfected the gums. And so you're in there mucking around where there's an infection. So, in a perfect world, what you would do is have the patient come in using ozone or iodine or some disinfectant agent. You would meticulously clean the sulcus around each and every tooth before you intervened, thus stopping the septicemia from your intervention. It's not hard to figure out where the bacteria are coming from when we do DNA analysis of the cardiovascular disease and the hip joints, knees that become infected from dental treatment. They came from the mouth. So I'm with Semmelweis. Wash your hands before you deliver babies. Disinfect gums before you muck around.
Agreed. Yeah. Oh, sorry, Griff. Yeah, microphone.
When you're using the water for lavage, how long is it stable for? Do you prepare it in the morning and it's good all day long?
We're preparing it. The ozonated water is good in your water bottles, your unit water bottles. Its half-life is 8 to 10 hours in a unit water bottle. And then in the refrigerator, it's good for 3 to 5 days. Frozen as an ice cube, it's good forever. So what we do is we're constantly making ozonated water, and so we'll make some the night before, and it's in the refrigerator. We make it in we store it in Knudsen fruit juice jars because they've got a nice little seal on the inside of the cap, and it's real easy for my staff, my team, to handle. I've made it in 5-gallon jugs. I've made it in everything. They like the 32-ounce jars because they can pick those up and go in and pour it in a water bottle. They're not lugging around some big, heavy water bottle. So we've got like 8 or 10 of those in the refrigerator at all times, filled up with either distilled, deionized, or reverse osmosis water. Something with that chlorine in it. The stopper fits, doesn't it, perfectly? Yeah. The Longevity sells a little stopper for those you can put in there, fits perfectly. Yeah.
When you use the ozonated gas, how do you hold it on that tooth for a minute? How do you control the gas?
You put it in a 10 cc syringe, which will actually hold 12. So you got 12 milliliters of gas. Put a flowable composite tip on. And then you put a saliva ejector between the tooth and the back of the mouth. Okay? That's going to scavenge all your gas. Then you flow it on for 60 seconds. So if that's 12 milliliters of gas in that syringe, you're going to put on 1 milliliter gas every 5 seconds. 5 times 12, 60. Okay? And you just go, say it's an MOD. You go from the distal box up over the occlusal to the mesial box, and then back up over the occlusal into the distal box. You just keep flowing it on there real slowly. And when you're finished, it looks like you acid etched the whole tooth. I've got nodding heads around here that have done those on course. So, and when that happens, all the bacteria that have been in the tubules are dead. all the organic material in the tubules has been oxidized. Now you've got a perfectly sterile surface to bond to, and there's no weep back of tissue fluid from the odontoblastic extensions from the dental tubules. You've got, those are all cauterized by that oxidative process. You've burned those off when you put that in there. And those bacteria, like you can go and look in the journals, about the cell membrane of a bacteria is negatively charged, so the ozone is sucked right to that. And it's positively charged, so the ozone is sucked right to that because it's negatively charged. So you get an electrochemical reaction. The question was how to use ozone for pulp capping. Well, first, don't expose the pulp. But no. But when you do that, there's two different techniques. If it's a direct pulp cap, say you're running along and you're prepping the tooth out, and this lower molar has tarodontism, and it's got some big old pulp horn where it shouldn't be, and you nick the top of it, you go like, "What in the world? I'm a moron. What? I didn't have done that in dental school." And so you look at that thing and you look and you go, "Oh wait, I've got the tooth isolated, right? I got a dam on. Okay." There's no infection in there because I've been spraying ozonated water on there. So that tooth is sterile. Okay? So you take an ozonated water, a cotton pellet, ozonated water, put it over the little exposure and let it set on there and check it until, if there's any hemorrhage, when the hemorrhage is stopped, then dry it lightly with another cotton pellet, and then you put ozone gas on that. Now this is where the dosage change. You use 25 microgram, 20 to 25 on there, because now you're dealing with soft tissue. When you're dealing with soft tissue, you have to use a lower ozone concentration than you're dealing with hard tissue. Hard tissue we consider to be caries in a tooth and root canals. Okay, that's when you use the 50 micrograms. And desensitizing teeth on the abfractions and the gingival recession, then use 50 at least. You can even use 60, okay? But then after you do that, then you put a spot of whatever you want to cap it with. Whether you want to do Theracal, MTA, whatever you like, cap that with that. And now go back and use your 45 to 50 micrograms to get the rest of the decay killed in there for sure. And now you're not affecting that very, very, very delicate tissue of the pulp. And then etch it, seal it, bonded, flow, pack,
Since you use ozonated water in all the lines and everything, have you noticed that could be like corrosive or damage the lines at all?
I haven't had that happen. A few people have. Most of the lines that we have, did you have some of that? Oh, really? Okay. Yeah. Mm-hmm.
And we're not sure if it's the ozone or my patients would ask me to give them warm water. So there's a heater you can put on the biojet.
Mm-hmm.
And so we heated them all. So then I called the company and said, no, it's the heater. No, it's the ozone. So, and it also went through my, something else I was using and we had to stop. We did the biojets and I can't remember.
Have you had any problems with anybody else had any problems with their water line? Yeah.
Just the biojets.
The Vijet? Okay.
And they said, what was the fault of the foundation of the...
Okay, but not your units, not your... See, I've got ADEC carts in both offices, and I've never had an issue with that, and I started putting ozone water in there in 2004 is when we started doing that as a biofilm.
Oh, in the containers on the outside?
Yeah.
Okay.
Yeah, with the...
Run through the tubings some other way. I don't know how we did it. I don't know. I had this company come in that changed all my water systems so that I had clean water in the office in general. And then he hooked up a line for just the ozone water.
Yeah, that's it. I mean, what we do is we take you say you got your unit water bottle, okay, and you fill it about halfway with distilled water, and then you fill it the other half with ozonated water, because ozonated water, when you make it, it's going to be about 22 microgram per milliliter concentration. You only need 4, maybe 5 to kill biofilm in your water lines. Okay, so that gives you 11 to 12 in your bottle. The half-life of that's 8 to 10 hours. So you still got 4 at the end of the day. So your biofilm is still controlled. one thing, if you do that and you haven't taken the ozone course that you'll hear us saying there, when you first put it in your water bottles, don't run it immediately with your hand pieces or your three-way syringes on. Take all the hand pieces off and run each one of them, because sometimes you'll get an unbelievable amount of biofilm come out of the lines. And I know because I clogged a Midwest high speed up with it, because I started off, I've got to do water bottle. What's going on? So I grabbed another one. Same thing happened. So I unscrewed the thing, looked at it, black, slimy, stringy stuff. I'm like, what in the heck? So we moved the patient to another room and we cleaned it out after that. So, yeah, straight ozone. So I cut it down. I cut it in half. Yeah, it might have been too strong for that. But most of my ADEC units, those are silicone tubings in there, so it shouldn't affect it.
For the ozonated olive oil, does that come in higher concentrations of ozone? Was thinking maybe that might be suitable for a little more control interproximally with some lesions.
Right now it's one concentration, but what's happened recently is they've been looking at just that issue, because they've done studies where they took guinea pigs and punctured their backs and then treated them with ozonated olive oil at certain concentrations. And the higher concentrations, if you kept using that on the whole healing cycle, actually retarded the healing after a certain while. So they're doing it now, and there's some new stuff coming out that'll probably be out this summer. It's a mixture of ozone and coconut oil, I think, where they've got 3 concentrations: high, pure olive oil; medium, with some coconut oil in there; and then low with a little bit more coconut oil.
The Pure 03 company, we get various oils, and it has different concentrations.
Right.
They also have different absorption, like the hemp oil.
Right.
So the thicker oil will stay on the tooth better, or something like that.
Right. Yeah. There's all those things that are studied. Yeah. So yeah. Oh well. Who's got the microphone?
I do. Hang on.
Okay.
Interproximal with the ozone? Are you doing repetitive on that?
Yeah, I think when you do an interproximal, like a incipient lesion interproximally, yeah, if you floss that out with ozonated water and then put it on either side, the ozone, you're gonna get some uptake in there. Yeah. Right.
But you don't do it over and over and over and over.
Yeah, we do it on the little kids. The hygienists do it. So we've got the protocols now. I'm kind of like, I'm in there doing the operative and stuff and injecting and trigger points and all of that. And so, I see the results. They come and say, hey, look at how good this is doing. Yeah, when did you start doing that? 6 weeks ago. Oh, good.
Okay, there's no more time. I'm sorry. Just grab him after. He'll be here.